What are your impressions of the Evis X1? What are the technologies that are outstanding to you?
Evis X1 makes the procedure more efficient in several ways. On the diagnostic purpose, the new zoom, the new brightness, the new NBI are very important helps to characterize the lesion. So on this point, it is again a gap for characterizing lesions. And the new things, with your new systems about the picture, for example, with TXI or RDI, we also have an additional information for therapeutic procedures, which is new. Before, all the image innovations were on the diagnostic, but now with the new Evis X1, we also have new pictures, new images for therapeutic to improve bleeding control, to improve the characterization of the submucosal fibers. And it is, for me, important to also have helps from the picture for the therapeutic purpose and not only for the diagnostic ones.
How does the endoscopic technology of Olympus increase your capability in finding polyps, increasing confidence in your diagnosis, and in saving time?
This new devices improves the detection, I think, because of the image itself with TXI, but also thanks to AI system, which improves the detection, not for all the lesions, but probably for some relatively difficult to detect. So for this one, the technology is very helpful, despite the fact we need more data from the literature now. And for therapeutic, it is also very important to have such a technology to improve the detection of the bleeding point, for example, to improve the bleeding control and the time to the reduction of the time to stop the bleeding, which is for me a very important source of stress, especially for the trainees and the guys with less experience, because bleeding is always a stressful condition, and getting a shorter time to have the hemostasis is probably a very important point for the user. So for patients, it's very good to improve detection, but also for the physician, it improves the quality of care because of reduction of bleeding time and of the stress of the physician who is performing the procedure.
Olympus is offering dedicated treatment endoscopes, PCF-H 190T for lower GI, and also GIF-H 290T. Both can be connected to the CV1500 of Evis X1. Which of them do you use, and what are the benefits for your procedures?
So we use a lot the PCF for everything, because we have everything we need. I mean, a 6 o'clock channel, a 3.2 channel, a flushing function which is directed on the device, and all these things make this endoscope a very important weapon for ESD, for example, and for new therapeutic procedure. We needed such an endoscope to have a weapon for the new therapeutic procedure, and this kind of scope offers all we need for new therapeutic procedures.
Talking about the Snare Master Plus, when treating polyps, do you see an advantage of having a hot and cold snare?
We want to have only one device that makes possible cold resection when it is feasible, and turn it to hot resection when the lesion itself is not cuttable by a cold snare. So more and more we are sliding to hybrid snares like you provide, because they offer a very good cold function, but also a hot one when needed. I should say that progressively we will use only one device, which is in the middle of the cold and the hot one.
Olympus has a variety of knives to meet different needs. In which clinical cases do you use Olympus Dual Knife J, Olympus Hook Knife J, and Olympus Triangle Tip Knife J? What are the specific values for each one?
My favorite is the Dual Knife J for quite everything, because I think there are a lot of work before providing this knife about the ceramic, the sliding effect. It is a very, very good device. The shape of the ceramic was thought to have a perfect sliding on the mucosa. And for me, it is very important to have a very continuous movement, and having something which slides on the mucosa make your movement more natural. So I should say that I have really a favorite with the Dual Knife J, which is my main device for everything. And the triangle knife is for me just a very rare case of myotomy, difficult case, but in fact, more than 95% of my cases are done with the dual knife J, which answer to many problematics and which is very precise for me.
What is your main expectation of ESD versus EMR after the ESGE guideline was updated?
So about the ESG guidelines and the place of ESD and EMR, for me it becomes really difficult to still provide a piecemeal resection for a lesion which could be a cancer. So if I was a patient, I would probably refuse to have my cancer cut in several pieces and lost information on histology. So the new guidelines which make ESD more and more important compared to EMR as soon as there is a low risk of cancer in the lesion are going in the same direction. I mean, for me, in 5 or 10 years, we will stop piecemeal EMR and we will go only for en bloc R0 resection with ESD or any new technique which is more simple technically, because it's the main problem of ESD. But on the principle, R0 resection should become the standard for every lesion, and for the moment ESD is the best way to achieve this R0 resection. So for my side, the place for ESD should increase again, and ESG is pushing in this way.
What are your expectations in mucosal closure with the new product SutuArt?
So about mucosal closure now, there is an unmet need in endoscopy, which is a simple and effective closure system to reduce the the adverse events like perforation and bleeding. So we really need something which is more simple than clipping, because we see in the large series that clipping is only feasible in 50 to 60% of cases, but not all. So we really need something new to have a good closure of the defect. And SutuArt, which is the needle holder new system, is very promising for this, because it seems that you can adjust your closure to any size and any shape of mucosal defect. You are not restricted to a small size defect, so it is very promising. We will see in the practice how much it is feasible and who can use it. Do you have to be an ESD expert to use it, or can we provide it for anybody to have a complete closure of a defect of a perforation? So it is for the common way of reducing adverse event after endoscopic resection, but it's also opened a lot of doors for future fields like fistulas closure, nodes procedure, opening of the wall of the bowel, go into the peritoneal cavity, come back and close it successfully. So for me, it is really an important opening on the future to cover the unmet needs we have to close very large defect effectively.